Hello everyone, and thank you for joining Ergo Medical this evening for an interesting discussion on the role of MMPs in delayed wound healing. My name is Tracy Patterson from Ergo Medical, and I'm the Key Account Manager from South Australia. Our mission at Ergo Medical is healing people and relieving the burden of wounds for patients and their caregivers. We believe in providing innovative
Hello, I wonder if anybody can hear me. It's Cassandra from Ergo Medical. If someone could just unmute and let me know that they can hear me. Yes, great. Lovely. Great. My name's Cassandra from Ergo Medical. It seems like we've got a bit of a technical glitch there, so I'm very sorry for everybody. And perhaps I can just take over from Tracy in regards to the introduction to this wonderful webinar we're broadcasting this evening. So Ergo Medical believe in providing innovative products that are supported by the highest level of clinical evidence. We'd love to hear from you during the presentation. Please feel free to pop in any questions in the chat and we will answer these at the end. And in the interests of time, if we do run out, we will be able to email you with any of the answers post this webinar. It is with great pleasure tonight that I introduce Professor Alison Cowan. Alison is a Professor of Regenerative Medicine and Senior Research Fellow at the University of South Australia. After completing her PhD at the University of Manchester, Alison moved to South Australia to join the Women's and Children's Health Research Institute. Over the past 25 years, her wound research has resulted in over 150 research articles, editorials, and book chapters in leading international journals. Alison is a Fellow of Wounds Australia, founding President of the Australasian Wound and Tissue Repair Society, and is the Editor of Wound Practice and Research, and the President-elect of the Australian Society for Dermatology Research. Thank you so much for joining us tonight, Professor Cowan. We look forward to hearing from you. Thank you very much.
Thank you, Cassandra, and thank you, Tracy, for inviting me to present today, and hopefully that you're back on track and you can still hear us. So what I want to do today, and I'm just going to try and minimize my there we go. Few technical issues. There we go. Okay, so tonight I want to tell you a little bit about the role of MMPs in delayed wound healing. It's a topic that I think is really interesting, and I'm pleased that so many of you have been willing to dial in and listen to this webinar. So I guess as an overview, I just wanted to briefly describe what is an MMP. What is their role in wound healing? How do MMPs contribute to delayed wound healing? And what new approaches are being developed or are currently available for treating MMP issues that are apparent in non-healing wounds? So just as a starting point, what is an MMP? So MMPs were first discovered over 60 years ago now, or in 1962 by Jerome Gross and Charles Lapierre. And interestingly, they were working on tadpole tail metamorphosis. And they found that for the collagen to be degraded in the tadpole tails, it required enzymatic activity. And they decided to name this enzyme collagenase. And that was the founding father, if you like to, if you want to think about it like that, of MMP1, and they named it MMP1. So a matrix metalloprotease is an enzyme that can cleave and rebuild tissues. MMPs act on specific protein substrates, such as the extracellular matrix, So those include collagens, gelatins, and proteoglycans. And importantly, they require a metal ion, such as zinc, at the active center of the enzyme. And that's where the name comes from. So you've got the matrix, metal, proteinase. So from the original discovery 60 years ago of MMP1, we now have a very large MMP family of metalloproteinases that has more than 20 members. In fact, at the last count, there's now 29 MMPs. They form different subgroups of proteinases, which include the collagenases, the gelatinases, the stromolysins, the matrolysins, the MT MMPs, which stands for membrane type MMP. And then there's a whole host of other enzymes that actually just don't fit with any of those subgroups. So you can see that there is a range of MMPs that have different activities, and some of these are more important in wound healing than others. The main ones important in wounds are the collagenases and the gelatinases, and you'll see that most of the literature talks about those two types. So MMPs are first produced in a very large, inactive pro form. And I think this diagram here nicely sort of describes the process of their activation. And enzymes are often sort of described as little tackmen, so they sort of have this diagrammatic shape of a munching tackman that can then go and cleave proteins. And what happens is that the active site is sort of filled with a pro-MMP protein that needs to be removed for that ability for the protease to be able to have its activity. And that can be done in two different ways, either by proteolysis, by a protease that can then degrade the proform, or by a process called allosteric activation, which can be a chemical such as SDS that can actually cause that the large inactive form to be dissociated from the rest of the protease. And once those large parts of the protein come away, the protease is active and is able to have its effect on the extracellular matrix. So how we look at this in the laboratory is through a process often where we call zymography or SDS page. And you can actually look at the different forms of these proteases by measuring the size of the proteins on a gel. And what happens there is that you have a gel that you can load with MMPs, and these are different sizes. So the size of the protein matters. The bigger the protein, the higher up it stays in the gel, and the smaller the protein, the more it can move into the gel. So you're able to quite clearly see where the pro-MMP forms of the MMPs are, and then you can differentiate how much of those are activated under different circumstances by the size of the protein. And you can also look at the different forms of these MMPs. So MMP9, for example, is much larger than MMP2. So you can use these kind of assays in the laboratory, at least, to be able to investigate the different activation states of MMPs. So MMPs are produced by a variety of different cell types, and these include cells important in the wound healing process. So these are your activated inflammatory cells, such as neutrophils and macrophages. They're the epithelial cells important in epithelialization, fibroblasts and endothelial cells that are important in the matrix and remodeling of the wound. And this diagram here just quite nicely shows the way they all interact, and you can have the pro-MMPs being produced by the different cell types. They're being activated by proteases, which might be produced in the blood, so the plasmin or the serine proteases, or by inflammatory cells such as neutrophil elastase. And those are activated into the MMPs and MT MMPs, as I mentioned earlier. And importantly, and I think what's really nice about the human body is that we often have this ability to self-regulate our cells and our cells' activities. And this is the case for MMPs, which have these tissue inhibitor proteins called TIMPs that naturally are produced by the cells to regulate the production and activation of MMPs. So I think what's important to take away from today's webinar, if nothing else, is that MMPs are actually really important, and they're particularly important for a normal wound healing process in acute wounds. So although we hear a lot about the adverse side effects of MMPs in chronic wounds, it's really fundamentally important to actually promote normal wound repair. And as I'm sure you're all aware, the wound healing is broken down into different stages. That starts with hemostasis and the formation of a fibrin clot, and platelet activation, leading into inflammatory phase of wound repair, where you see all the neutrophils and macrophages being produced, and they can secrete MMPs. And then this leads into a granulation stage of wound repair that involves angiogenesis, where fibroblasts and endothelial cells produce different growth factors and different cytokines to promote the fibroblast infiltration into the wound space, and also help to produce that new blood vessel growth. That also involves revitalization, and you can see how keratinocytes are then need to be activated to be able to revitalize the wound space, and leading into the final stage, which is tissue remodeling, where collagen, which has been laid down within that wound, needs to be remodeled into a more substantial dermis. So each of those phases, as I said, actually fundamentally require active MMPs. And they are produced by neutrophils and macrophages and fibroblasts, particularly MMPs 1, 2, 3, 9, and 13. And the purpose of these MMPs is to help remove any damaged extracellular matrix that might have occurred in response to the trauma or the initiation of the wound process. And they're also important for getting rid of any bacteria that might contaminate the wound site. They're also really critically important for promoting the migration and proliferation of keratinocytes. And just to sidetrack a moment, so some work done by David Leper's group almost 20 years ago now clearly showed that MMP9, for example, is upregulated in wound fluid of acute healing wounds. And what's important is that you get this initial upregulation of MMP9 in response to injury, but then it gradually goes down over time as the wound heals. And he showed this in several different types of acute surgical wounds, showing the importance of the production of MMP9, and other types of MMPs have also been shown to do this. And why this is important is particularly for revitalization. For the epidermis to be able to migrate and fill in the wound site, which is shown here in a histological image of a wound, the epidermis has to be able to migrate across the open wound surface. And the only way that the cells that are attached very firmly to the basal membrane of the epidermis are able to mobilize themselves and move across the surface of the wound is by these proteases. So, for example, MMP7 cleaves the junctions that hold the cells together. MMP9 has been shown to degrade the basal membrane components of this interaction. So this loosens the cells. Sorry, my mouse is very sensitive. So it loosens the cell attachment and enables them to then move across and migrate across the cell surface, the wound surface. And then you also need other MMPs to enable this process further. So all the other cells are then able to reform and mobilize and move into the space. So you can see that MMPs are important, and we do need them in an actively healing wound. Within the remodeling phase of wound healing as well, they're critically important for that breakdown of collagen, which is often in the first instance, collagen 3 is laid down in the granulation tissue of a healing wound, but that then needs to be remodeled into collagen 1. And that is done through the activity of the collagenases and the other enzymes, particularly the elastases. And if that doesn't occur, then you get this uncoordinated deposition of collagen within that chronic wound situation. If you have too many collagenases, then the dermis fails to form and you get the impaired healing response. That can then also lead to increased inflammation and overall delayed healing. Within a scar, if you have too much elastin fragmentation, that can lead to a stiff ECM. So while it's critically important that these MMPs are available within a normal healing wound, you can see how if they're there for too long, and that's then you get the chronic wound situation occurring. As I mentioned earlier, we're lucky that we have this inbuilt regulatory system within our cells that produce these natural inhibitors of MMPs called TIMPs. And these endogenous regulators are really clever, and they're able to realize in a normal situation when too much MMP activity has occurred, and they need to come in to either get rid of those MMPs or to help break them down. And there is a range of these inhibitors. There's 3 known TIMPs, 1, 2, and 3. And those 3 TIMPs have different substrates, so they act on different MMPs. And they've been shown to be present in different types of wounds, so excisional wounds and burn wounds. They've been shown to both impair and accelerate cell migration in vitro, and they've been able to be shown to be able to control remodeling. So overall, MMPs are absolutely essential for normal wound healing. We know that the MMPs are produced during the inflammatory phase for the removal of damaged extracellular matrix and bacteria. We know that they're then important for angiogenesis and the proliferation phase of wound repair. They're important for degrading the capillary basement and for basement membrane, and they're important for helping epidermal cells to migrate. And then they're important for remodeling, so to help the contraction of the wound edges that can help to form the intact dermis. So what happens when all that really nice regulatory system does not occur? So what happens in a chronic wound situation? So here we have what happens in a chronic wound. So here, high levels of MMPs, which fail to be resolved either by the TIMPs and not being activity, either the TIMPs aren't present, or we're just getting too much production of MMPs. That's when we run into problems, and that's when we end up with delayed healing responses. So several studies have shown that chronic wounds do possess very high levels of MMPs, and much higher than what you would have normally seen in an acute wound. And you can see here that MMP1, for example, in acute wound is relatively low compared to how much is found in a chronic wound. And you can see that, as I said earlier, in an acute wound, we get this initial upregulation of MMP1 in an acute wound, but it's rapidly resolved. Whereas in a chronic situation, you get much higher levels of MMP1 production, for example, and it doesn't resolve. So that seems to be the crux of the matter. And many clinical trials have now been investigated to look at the levels of these MMPs within the wounds or within the wound fluid. And it's been shown that this is across the board in venous leg ulcers, in pressure injuries, in DFUs, in all sorts of different types of wounds. You see this continued elevation of MMP activity. Another study that was done here in Australia by Z. Upton's group in Brisbane showed that wound fluids, again, it's a similar story, but this time they focused on MMP9, and they collected wound fluid from acute wounds and from a range of different chronic wounds and collected all the different wound fluids and then measured MMP9 activity. And they also saw very high levels of MMP9. Importantly, what they also did was then to look at the push scores. So how chronic was the wound, how long had it been present, and whether or not it was in a healing or non-healing phase. And when they did this, they found that there was a correlation between the push score of over 12 was correlated with very high levels of MMP9, compared with a push score of less than 11, which had much lower levels of MMP9. So they were suggesting that the level of MMP9 within a chronic wound could be used as a potential diagnostic protein for indicating the severity of the wound and whether or not it was likely to heal or not, and also potentially as a target for interventions for potentially reducing the amount of MMP9 may help to improve the healing response. Other studies in diabetic foot ulcers have also looked at the ratio of MMP9 to TIMPs, the natural inhibitor. And what this study showed was that this ratio of MMP9 to TIMP was really important. and they found that there was a much higher level of MMP9 to TIMP in wounds that failed to heal. And they did this for MMP9 again and also for MMP2. So the rates, so clearly the more, and it is relatively obvious, the more MMP2 and the less MMP TIMP you've got would indicate that the wound is likely to have impaired healing responses. So clearly, increased levels of MMP activity may be due to various reasons. It could be due to increased expression of MMPs. So we're seeing, and this has been shown to be true for MMP2 and MMP9, which are gelatimases. There's much higher levels of these proteins in venous leg ulcers. There's much higher levels of collagenases, particularly 1, 8, and 13, in different types of wounds as well. And there's also high levels of streptomycin and matrice. So clearly we've got elevated levels of all these different MMPs in these wounds that are failing to heal, as well as the downregulation of their inhibitors, both TIMP1 and TIMP2, TIMP1 and TIMP2. So it's this unchecked activity of MMPs is important as it's destroying proteins as well as excelling matrix molecules, because it's been shown that MMPs can destroy growth factors, which are important for stimulating healing responses, as well as degrading all those collagens and other excelling matrix proteins that are important for wound remodeling. So there was a really nice review a few years ago in the Journal of Wound Care that looked at the review of all the clinical evidence about MMPs in chronic wounds, and they came up with a series of findings, which I've just mentioned here, and they said that chronic wounds, including venous leg ulcers, DFUs, and pressure injuries, and other types of surgical wounds that have become chronic, all have elevated MMP activity. They discussed that the MMP levels were higher than those recorded at any time in a normal healing acute wound, and that the initial high level MMPs have been correlated to significant delayed wound healing in chronic wounds of various etiologies. They suggest that the elevated level tends to decrease while the wound is put back on the right healing trajectory and healing occurs. So if you can restart the healing process, then the MMP levels can go back to a normal level. So they're not always going to be high. You can kickstart that healing process. So the overall suggestion was that therapies directed at modulating MMPs would have a significant promise in ulcer healing. So what I want to do in the rest of my presentation to you all is to just talk about some of the recent advances for modulating MMPs in chronic wounds. And I've divided these into 4 different approaches. So clearly diagnostics are an important area of approach, and the development of therapeutics, the development of various dressings to reduce MMP levels in wounds, and also different devices that can be used as well. So I'm just going to briefly take you through these different areas of advances. So with the diagnostics, clearly, you can't actually see MMPs. There are no clinical signs when you look at a wound to know if it's got high levels of protease activity. So that's the first difficulty. So there are several advanced techniques that have been used in laboratories to analyze levels, and I mentioned it earlier in the talk, that you can look at wound fluid and biopsies by different ways. But these also include in situ hybridization and qRT-PCR. So PCR is used to measure gene expression. So potentially you can look at, you can take a wound biopsy and look at PCR in the laboratory in gene expression. ELISA is a method that we can use to look at protein levels, generally in biopsies or wound fluid. Zymography is the approach that is used to look at protease activity on a gel. And then there's various fluorometric assays, but those really are more laboratory-based assays rather than ones that could be used within a clinical situation. When we're looking at measuring MMPs, there's various different ways for collecting them. from the wound itself. So I've just shown here a schematic of one approach that's used to collect MMPs from the surface of a wound. You can use a swab just to I guess collect the surface of the wound fluid that might be present on the surface of the wound. The tip of that wound fluid of that swab can then be placed within a microfuge tube and stored for -80 degrees for any length of time. And then when you want to analyze it, you can add a buffer to the tube, mix it with in a vortex just to really get the proteins off the swab, invert the swab so that the swab is no longer within the liquid, and then centrifuge it at high speed to elute all of those different proteins. And that then gives you a final sample containing MMPs, which you can then load on gels, for example, like I showed earlier, which can then tell you what MMPs are present in a laboratory. Clearly, that's not the best approach for the clinics. And there was a round table, which is 10 years ago now, which is amazing to think this. But at the round table, they talked about all the different types of diagnostic approaches for measuring MMPs. And they identified that diagnostics would help clinicians to select the appropriate therapies for particular wounds. And that a diagnostic that could identify what MMPs are present and what levels of MMPs are present would be a useful indicator to enable the decision-making process of what therapies could be used or what therapies should be stopped. They also suggested that only if a wound continues to not progress would you actually start to use a point-of-care test for protease activity. There's no need to use this approach in a normal healing acute wound, for example. And they also thought it would be useful to have a diagnostic because not all advanced dressings work on every type of wound. So it would be important to know which wound type would be most useful to be treated by different approaches. So there's not many approaches currently available for measuring protease activity within a wound. Wound check is one approach that was first developed by Cystogenics, but has now been taken over by wound check laboratories. And this is a broad approach to measuring proteolytic activity within a wound. So what happens here is that you use a swab, like what I mentioned before, and then you're able, what this test does is to develop a dipstick, which pretty much gives you a window of whether or not you've got a wound or not, sorry, protease activity or not. And you get a window, and if you have elevated levels of proteases, you get two bars on the window, like a pregnancy test. And if you get only one if you've got elevated levels, but if you have low levels, you get 2. So as you can see, this only gives an overall indicator of proteases that are present in the wound. It doesn't identify specific proteases. It doesn't tell you if you have MMP1 or any different types of MMPs within the wound. So while it's useful to get a feel for how, if you've got a very proteolytic environment within the wound, it has limited ability to be able to differentiate whether or not, what type of proteolytic activity is occurring there. A few years ago, we tried to develop a more specific type of approach to measuring MMPs. So with a collaboration with Nico Volker, who's at Monash University, we were looking at developing specific diagnostic sensors to measure individual MMP activity. So in this situation, we were using an MMP inhibitor that was specific to MMP1. And we used this inhibitor and attached it to the surface of a biosensor that changed its reflectance if the MMP was then present in the wound fluid that we were putting the sensor into. And if the MMP bound to the inhibitor, then we were able to see it using a spectrophotometer. And this just shows that in wound fluid, we were able to measure MMP activity using this approach. So this is a bit more of a specific targeted diagnostic. But clearly this also has its limitations, because we know that there are many different types of MMPs that are present within the wound, and we would potentially need to develop a sensor for all the different types. And we'd also need to know what level of MMP activity in the wound is important as an indicator for clinical use. So as part of trying to understand, how much MMP is good, how much MMPs are bad, what level or type of MMPs are important, and various studies have been conducted, and one was published in this journal, Journal of Wound Care, that looked at the clinical evidence for the level of MMPs that are present within the wounds. And they did a review of different trials that had looked at MMP levels within the wound fluid of these different groups of patients, so DFUs or neuropathic DFUs in general. And they looked to see what if there had been any quantitative analysis of the levels of these agents within the wounds. However, what they found was that no study had been able to identify a global MMP threshold. So how much MMP is too much is still not known. And there was no study that was able to show if there's multiple MMP types present at the same time, and if so, what level of those MMPs is too much. They did identify 3 studies that proposed a threshold based on a combination of markers. So they looked at MMPs plus TIMS plus TGF-beta and found that provided a more stricter threshold on MMP activity. But overall, they found that there was no consensus at this stage on the value of the best MMP threshold that could be used to predict general wound healing. So the jury is still out. It's still a work in progress. There's still a lot of work that needs to be done on developing diagnostics, but I think it's still an important area that needs further investigation. So moving on to protease therapeutics, this is also a really complicated area, and I think, and I hope you can realize that developing approaches targeted at MMPs when there are so many of them is really challenging. So the researchers have looked at small molecule inhibitors, they've looked at antibodies that are specific to individual MMPs, they've looked at more general protease inhibitors, and then specific MMP inhibitors. There've also been some work done on tetracyclines and whether or not low-dose doxycycline and minocycline can be used as protease inhibitors. And this diagram here I just thought was nice because it shows how the more complicated, I guess, the approach. So moving from a small molecule inhibitor to an antibody to a more endogenous inhibitor, the increased specificity you will get, but it's also a more complex situation. So one preclinical study using diabetic rats was published in PNAS, which is a really good journal. And what they did was to combine a protease and an antiprotease together. And they found that by doing this approach, they could actually improve healing of diabetic rats. So on its own, they looked at the protease inhibitor ND336, which inhibits gelatinases MMP2, MMP9, and also it inhibits MMP14. So that has quite a broad inhibitory effect. And then they also looked at MMP8. And they found that if they combined, so individually, they all did actually improve healing responses by improving the rate of wound closure when they added the broad spectrum inhibitor or MMP8 on its own. But they actually found that when they combined the two together, they got an even better response. So this is quite a complicated approach, but it shows the complexity of the issue that we're trying to deal with, that multiple proteases require specific inhibitors and approaches to be able to stimulate healing of impaired healing responses. Another interesting approach is this use of tetracycline antibiotics. And I thought this was interesting because it suggests that derivatives of tetracycline are able to inhibit MMP activity independent of their antimicrobial action. And various MMPs have been shown to have different sensitivities to these different tetracyclines. For example, the strongest for MMP8 and MMP13, but with very weak or absent sensitivities in MMP1 and MMP3. And using sub-antimicrobial doses of doxycycline was able to improve the healing of chronic venous leg ulcers in a small clinical trial. There's been little follow-up of this, and I don't know why that hasn't become more evident, but I thought it was just an interesting approach to be able to potentially use an antibiotic to decrease the level of MMPs within a wound. So there's not many devices specifically targeted to removing protease activity within a wound, but negative pressure wound therapy has been suggested as one option to do that. And this is really a secondary effect of this approach, because it wasn't developed as a way to get rid of MMPs, but the fact that the negative pressure is removing wound fluid and from the surface of the wound, I guess, just naturally takes the MMPs with it. And there's been a few studies just to assess that. And it was shown that you get lower levels of MMP9, low levels of MMP9 to TIMP1 ratio in these negative pressure wound therapy treated wounds, and also decreased levels of MMP3 and lower ratios of MMP3 to TIMP1 when also treated with the negative pressure wound therapy. So I think that's an interesting concept and may be a good byproduct of that therapeutic approach. Finally, I just want to talk a little bit about MMP modulating dressings, and these are probably the most commonly used approach to decrease proteolytic activity within a wound, and they're probably having the most success compared to the other approaches I've been talking about. These products have been designed to reduce excessive proteolytic activity and rebalance the wound environment. They have also been developed so that they absorb the wound exudate. So again, they're taking the MMPs out of the wound environment and holding them away from the wound within the dressing structure. There's two main types available at the moment. There's the oxidized regenerative cellulose, the ORC, or the ORC, I'm not sure how you say that, mixed with collagen, which is permagran. And then there's also the sucrose octasulfate dressing by Ergostat. And I just want to point out that I haven't been asked to talk about Ergostat tonight, but I felt that it would be remiss of me to not talk about this dressing, if I'm talking about these modulating dressings which are currently available. So the collagen ORC dressing is a protease modulating matrix comprised of a sterile freeze-dried composite. This sounds complicated. It contains 45% oxidized regenerative cellulose and 55% collagen. There was a really nice review on all the review and evidence of this type of dressing, which I would recommend that you have a look at if you're interested in this approach. And what this dressing does is that when the collagen ORC matrix comes into contact with fluid, it absorbs the liquid and forms a gel, which traps the proteolytic proteases inside and prevents them from then having any further effects within the wound space, which is what the gel physically binds to and inactivates damaging proteases, both MMPs and elastase, that are present within the wound. So just one case study using this approach in a lower extremity wound showed that after 7 days, the wound was starting to granulate, and over the 21 days of treatment with the ORC collagen, and this one actually has the silver dressing part of it to it as well, the wound healed nicely. I guess the only problem with the case study is that we don't know how that wound would have healed without the dressing, but I think there's significant body of literature now that suggests that this type of approach does work. And the panel that discussed this review of evidence did make recommendations for the use of this dressing, and they recommended it could be used in various different indications. I guess I'm a little bit hesitant about the use of this type of dressing on donor sites and acute wounds, having already mentioned the fact that we do need proteases in a normal healing wound for it to have, promote activity. So if you're mopping them up in an abrasion or in a donor site or any form of surgical wound, then potentially that's not the best approach. But the conclusions of the panel looking at all the evidence was that this bulk collagen dressing would be important for clinicians to help manage chronic wounds, but that further clinical and economic studies are required to be able to evaluate the cost per use of this type of approach. So finally, that brings me to the lipido-colloid nano-oligosaccharide factor, the TLC NOS dressing. So this is the ErgoStart and has been shown to have two modes of action. So it's a protease inhibitor that prevents the continued degradation of the ECM by MMPs, and it's been shown to promote angiogenesis through the migration and proliferation of endothelial cells. There's been a lot of clinical trials looking at ErgoStart, and I think the fact that the Explorer trial was published in Lancet, the Lancet Diabetes Endocrinology, which is probably one of the best journals out there internationally, shows a level of evidence that's been produced to support this dressing. And what they did in the Explorer trial was to conduct a multi-center European double-blind randomized control trial comparing the ErgoStart with a non-interactive dressing. And they found that there was a statistically significant increase in wound closure and a statistically significant decrease in wound area with the ErgoStart compared to the control. They also conducted a reality trial, which was actually just a pooled analysis of a very large number of patients, either with venous leg ulcers or diabetic foot ulcers, and followed those up for between 4 and 20 weeks, and found that this study also supported the use of ErgoStart. And then there was an earlier challenge clinical trial that used the dressing in venous leg ulcers. And they showed that there was a reduction in relative and absolute wound area compared to a non-interactive dressing. So just one set of data that showed the use of the sucrose octasulfate dressing in diabetic foot ulcers from different parts of the foot where the injury was, showed that there was a significant improvement in wound closure, which was independent pretty much of the site of the DFU on these diabetic feet, and nicely showed an improvement in healing responses. So as you can see, there's a range of different approaches that are currently either under development, being developed in preclinical trials, clinical trials, or currently on the market. I think this is a field that has a long way to go, particularly in the range of diagnostics and therapeutics. But I think that there is a lot of need still for a really targeted diagnostic and a targeted therapeutic approach to reduce the level of proteases that are present within a chronic non-healing wound. I think the dressings are really established really well. There's a lot of clinical trials that support their use, but I think having the other approaches would also really support and validate their use even further. So just finishing off here, this was done in 1996 by Greg Schultz, who is an expert in this area in MMPs, and this was the hypothesis that was done over 25 years ago on chronic wounds. And clearly, even back then, we knew that repeated tissue injury, bacteria, biofilms all stimulate increased inflammation that leads to production of high levels of neutrophils, macrophages, and mast cells. as I said earlier, those cell types in particular produce large amounts of MMPs. They produce that imbalance of proteolytic activity being produced because of the elevated inflammation leads to high levels of proteolytic activity, high levels of ROS, high levels of nitric oxide production, which all contributes to the destruction of essential proteins, decreases growth factors, decreases the ability of cells to migrate, decreases extracellular matrix functions, and reduces cell proliferation. And I think this hypothesis that was put forward 25 years ago still holds today. This is exactly what research is showing. It is well supported by the literature, and it clearly leads to a failure of an acute wound to heal and a contribution to chronic non-healing wounds. So we still got a lot of work to do to really identify what happens next. But just in summary, we know MMPs are essential for normal wound healing, so we don't want to get rid of them. We don't want to be putting anything on a normal healing wound that's going to get rid of those MMPs. We do, however, know that dysregulation of MMPs occurs in chronic wounds, and that prolonged expression of MMPs destroys growth factors and extracellular matrix, leading to impaired ability of those wounds to heal. We know that in a chronic wound, MMP levels are higher than those recorded in normal healing wounds, and that this elevated level of MMP correlates with clinical impaired wound healing. So being able to reduce the levels of MMPs in chronic wounds is likely to lead to improved healing responses, and is a worthwhile approach for clinicians to take in their practice. So that's all I have to talk to you tonight about. So if you have any questions, I can't promise I'll know all the clinical answers, but I can at least give it a go. Thank you. So if I stop sharing.
Thank you so much, Professor Alison Cohen. That was absolutely excellent, and I'm sure the audience thoroughly enjoyed your presentation. Certainly learned a lot more about MMPs through your discussion. So we're more than happy to take questions. So I'll just jump onto the chat. So we've got a question from Samantha, and she's asked, so can we request in pathology, a pathology request form MMP test with wound swabs? So I think she's basically asking if you can request an MMP test through pathology.
Not that I'm aware of yet. I think at the moment, all pathology isn't set up to do the kind of assays I was talking about, which is why we do need to do more research, because they don't have that ability at the moment. So I'm sorry, but not at the moment.
And we've got another question here. Are the same MMPs, i.e. 1, 2, 3, 9 and 13, evident in cancerous wounds, i.e. after prolonged wounding? Do they behave similarly to other chronic wounds?
That's a really good question, and one that I haven't actually investigated. So I would expect so. I would not expect that they would have gone anywhere. And if anything, I think that they are going to be critically important in continuing that destruction of the dermis, that chronicity that contributes to those cancers forming. So I don't know the exact answer, but if I was to take a guess, I would say I would expect them to be there.
Excellent. And I've got a question from Jacinta Barlow. So hi, Alison, thank you for a wonderful, informative presentation. I'm just wondering what you see as the big picture issues in wounds research and how these impact on clinical evidence. Oh, sorry, clinical practice.
Jacinta, that's a really difficult question. I think just from tonight's presentation, clearly there's a lot of work that we need to do in the diagnostics part of MMP. I think that if we could get a much better handle on MMP activity and the specific levels of MMPs in a wound, then I think that would help guide clinical practice. Bigger picture, I think we still are a long way away from that ability to be able to cause regeneration of skin. And to me, that is something that I'm really keen to try to promote. Why do we have to, have scarring? Why can't we regenerate skin? But, that's a new, a talk in itself, and I would love to be able to do that one and perhaps think a bit more about what the next big pictures are. We're developing antibodies at the moment that we can inject into patients to try to stimulate the body's natural healing responses. We're also trying to develop different really clever silver dressings that only produce silver, for example, when it's needed rather than all the time. So having sort of a responsive dressing that reacts to the situation rather than just as always delivering agents. So there's a few different things that are on the cards. Being able to measure temperature is something that we've just got a funding for, and that seems to be really important within a wound. If we can measure when a wound starts to get infected by a change in temperature, that might allow an early indication of when to start treating wounds or patients with antibiotics. So there's a few little things out there that I think could help to improve outcomes.
So we've got another question. Do we know if hyperbaric oxygen therapy has any effect on MMPs?
I don't know. I'm sorry, I don't think I've seen that, but we know that we know that other factors can contribute to MMP activity. So maybe, I'm sorry, I don't know the answer to that one.
And we've got another question here. Are there higher levels of MMPs in moist burn wounds than other wounds?
I wouldn't expect so. I don't think, I would have thought that they would have a similar, I guess, repertoire of MMPs as a chronic non-healing wound. But again, I haven't looked at that question, so maybe I can take that one on notice.
No problem. We can give you a copy of all the questions and we can get back to, all the people that have answered the questions with the answers. So I'm just going to round that up and just say thank you so much for everybody for joining us this evening, and a huge thank you to you, Professor Alison Cohen. That was an excellent presentation. We've all thoroughly enjoyed the evening, and we hope to see you all in the future at future Argo medical webinars. And thank you very much for attending with us this evening. Thank you.
Thank you. I hope everybody got something out of it and enjoyed spending their early evening with us.
Thanks again, Alison.